Good evening, and welcome to our symposium today on coordinating transformative care in non-Hodgkin's lymphoma, or NHL. Today, we are really excited to bring to you a lot of great information. We have panelists myself, Amanda Yepes, and Tiba Al-Sagheer. Welcome, Tiba.
Thank you. Thank you, Amanda. Happy to be here.
And we just wanted to start off by saying thank you to PeerView for providing this session, and Bristol Myers Squibb and Novartis for the educational grants. There will be a lot of engagement during this symposium today, so be on the lookout for polling and respond to the questions on your screen as you see the prompts come up. And then if you have any questions along the way, please use our chat window to enter the questions I will address as we can throughout the presentation, and definitely leave some time at the end as well. There's a lot of great additional information at peerview.com. The link is here, all of the info, as well as their links to Twitter or X. And with that, I will get started with an introduction on the CAR T era within non-Hodgkin's lymphoma. But first, let's get started with our very first poll. Which of the following best describes your involvement in the delivery of CAR T? Where are you working? Are you actively involved in CAR T coordination management, primarily involved in supportive care? You have limited involvement and want to learn more today, or no direct involvement, also want to learn more today? We'll give you some time to answer the question on your screen. Okay, so it looks like most of us today are actively involved. It seems like we have a very good mix. So we're very much looking forward to speaking to all of you who are involved in the CAR T process or looking to get more involved, especially after this presentation. With our presentation today, our goal is really for everyone to be able to understand the current guidelines and evidence that support the integration of CAR T therapy within the lymphoma space, and really understand the role that pharmacists play in coordinating care for these patients, whether it's preparing safety management resources or looking at effective care for delivery, and looking at real-world examples and literature. Lastly, our goal is that we learn about educating our patients about therapeutic and safety expectations within CAR T products. So taking a look at where we are today within the United States, the indications for CAR T have significantly expanded across both products and disease states within non-Hodgkin's. So you can see with this chart, Tisa-cel has been approved after 2 or more lines of therapy in both large B-cell lymphoma and follicular lymphoma, while Brexucel remains its approval within the mantle cell space. But what I really want to highlight here on this slide is the earlier lines of therapy that both axi-cel and liso-cel are indicated for within large B-cell lymphoma. So really, this allows us to offer CAR T to more patients as early as second-line therapy. Now, both axi-cel and liso-cel have further approvals in later lines in therapy in the large B-cell lymphoma space, as well as after 2 or more lines of therapy in follicular lymphoma. Liso-cel also has indications in mantle cell, MCL, and CLL, but our focus today is really going to be within both the large B-cell lymphoma space, follicular lymphoma, and we'll touch on some other things along the way. But I think what's really critical here is being able to offer those patients CAR T as early as second line. And despite these earlier approvals, real-world data suggests that there is a slower uptake of CAR T in the space, in that second line in large B-cell lymphoma, despite patient eligibility. So we see here data taken from the US Flatiron Health database of over 800 patients, and it showed that only about 16% of patients receive CAR T second line despite regulatory approval. This leads us to ask what really goes into the decision making of CAR T, and where do pharmacists play a role within that? So with that, I'd like to turn it over to Tiba to further discuss where we stand with CAR T in non-Hodgkin's lymphoma.
Thank you so much, Amanda, for that introduction. So I will basically now take us through where we are and basically what are the barriers and the issues that we're facing with CAR T. So in your practice, when does your team typically introduce CAR T options for patients that have diffuse large B-cell lymphoma? This will take us to a polling question. Okay, so it looks like we have a mix majority. Looks like after the first relapse, so second line eligible patients, and it looks like about 20% of the audience actually does discuss CAR T cell therapy at the initial diagnosis, which, we think that's something that's really important and critical because many patients at the first relapse, they're already overwhelmed with so many different things, and CAR T may seem like a foreign and very complicated process for them. So maybe that real world data that Amanda presented is impacted by when that CAR T cell therapy is really introduced and when the patients are aware and learn about that therapy. So it's really nice to kind of have that mix. And again, it's not wrong to bring it up at the first relapse as well, because that's really when most of the centers are using it on label if a clinical trial is not available. Excellent. So now we're going to kind of look at how pharmacists are really involved in that CAR T journey and where we can really have an impact on the patient care and outcomes. So we have two cases that will follow us throughout the presentation. The first one is a 60-year-old patient with a performance status of 1 that has diffuse large B-cell lymphoma. This patient has an early relapse that has been confirmed at 6 months after treatment with first-line R-CHOP. And the second patient is an older patient at the age of 72 years old with relapsed refractory follicular lymphoma. This patient has a rapid disease that is progression after 2 lines of therapy and has already received BR followed by R-squared or lenalidomide rituximab. So now Amanda and I are going to discuss how this is really how we're going to go about these patients. So in each case, how do the current evidence and guidelines support the use of CAR T cell therapy? And then what key factors and disease-specific considerations inform patient candidacy, as well as how would different functional status or comorbidities would inform our choices? So I'll kick it off with starting off with the case number 1 or patient number 1. So in this case, do the current guidelines and evidence support taking this patient to CAR T cell therapy? And the answer is yes. We have clinical data and evidence that we can actually take this patient since the relapse occurred within the first 12 months to CAR T. And we have 2 products that are currently approved and available that are also supported by the NCCN guidelines that we can use. And the same thing that would happen for the 72-year-old patient. And Amanda, if you want to walk us through how you would go with that 72-year-old patient.
Right. So these patients both are eligible for CAR T therapy. And looking at the second patient case, and thinking about how this is a patient with rapid disease progression, it's a high-risk patient population that may not receive additional benefit from more conventional therapies. So CAR T really here offers the potential for deep and durable remissions. We have lots of evidence to support this, Zuma-5, other trials. And in this patient case, being 72 might make us pause a little, but age alone does not preclude anyone from receiving CAR T. It's going to come down to their functional status, their comorbidities, and other logistical factors that we'll discuss. And I think I saw a chat question come in about what factors most influence our recommendations for CAR T versus additional, more conventional therapies. And I think it comes down to um, how quickly did they relapse, what were they given beforehand, and then but what we really focus on it are is CAR T logistically feasible for that patient. That's something we're definitely going to dive into deeper later on in the presentation. But do they have access to a CAR T center? um, are um, are they functionally fit and have a good performance status to be able to tolerate the CAR T therapy.
Absolutely. I agree with Amanda. So it's a puzzle that we need all the pieces to align in order for us to take a patient to CAR T. So definitely both patients here are candidates for CAR T cell therapy. Many factors such as performance status that we take into consideration. And then that also seeps into now when we have multiple products, how do we actually go about that? So for example, the case number one on this slide over here, we see that the second line preferred options in the primary refractory or early relapse, we have Axi-cel and Liso-cel as options that we can use. So if you had these two in your center, which one would you really take into consideration? Can the patient tolerate an agent that may have a slightly higher toxicity profile? Is the preference to do outpatient administration or inpatient administration? That's really where we tailor which product we go through. And the same thing with follicular lymphoma. We actually have three products. So assuming your center has all of these three products, which one do you choose? You're going to look at that obviously efficacy profile, but also toxicity profile and feasibility for the product. So it's really important that we look at the patient as a whole, as well as the disease and the product specific factors that will allow us to select what we're going to do for the particular patient. So now that we talked about Axi-cel, so we know that in ZUMA-7, it was studied for the diffuse large B-cell lymphoma and the ZUMA-5 with the follicular lymphoma space. It showed pretty good overall survival, durable responses in both disease states. So we know that it works in aggressive as well as indolent lymphoma and with really good numbers and efficacy. However, we do know that this product is associated with some toxicity. So we do see that grade 3 or higher CRS is reported at about 6%, with ICANS at about 20 to 21%, depending on the study. And many of you who have CAR T in your center, you may see that those numbers can fluctuate depending on the patient and their risk factors and disease burden, etc. So yes, the product is efficacious, but we also have to be very mindful of the toxicity profile and how we are going about the strategy of managing those toxicities and being proactive and prepared for the monitoring and the coordination, ensuring that we have all the supplies to address anything that may occur during the therapy for the patient. Now, with Liso-cel, it's yet again another product that is efficacious across aggressive and indolent non-Hodgkin lymphoma settings. You can see with the Transform, it showed superior median event-free survival compared to standard of care. We have pretty good overall survival, as well as in the pilot study with good overall survival at the 5-year mark, and with follicular lymphoma in the Transcend follicular lymphoma study with CRs up to 94%, as well as sustained progression-free survival and overall survival. So we really have good outcomes here with this product as well. And we also know that the toxicity profile is on the milder side. So this may be a product where you would choose for an elderly patient or someone who may have more comorbidities, because if a patient cannot handle higher grade toxicity, for instance, even though we know the other products are also very efficacious and work very well, this patient may experience quite a bit of toxicity. So if we were to look at the previous cases, maybe for case number one, we would go with like an Axi-cel product, given the patient's age being younger, good performance status with meeting that label. And then for the follicular lymphoma patient, perhaps we could, given the older age, we may be able to give the lysocell and maybe even administer lysocell in the outpatient setting if the patient is otherwise healthy and can tolerate that. Now, we also have Tisa-cell, which is another product that is also an option for, let's say, our second patient case with follicular lymphoma, which has shown also durable remissions and favorable long-term safety profile. So we can also administer this product in the outpatient setting, especially given that there are such low rates of severe CRS, as well as no grade, basically no grade 4 or higher CRS or higher grade neurotoxicity. So again, it's nice that we have all of these options for the patients, and it's important for us to bring this up as early as possible during the discussion, just so it is on the radar for the patient. Now, it looks like one of the questions that came up was this patient in the chat, where we have a patient that perhaps lives far from the treatment center, and that what factors are we looking into? So I mentioned a puzzle earlier, and this is really the puzzle that I was referring to, is that yes, the patient may meet the FDA approval, the label, all the criteria, but we may not necessarily be able to administer the therapy logistically because the patient lives very far away from the cancer center, or they may not have a caregiver that can care for them, and we know that these products do have toxicities that will need to be monitored, where the patient would have to be close by and have supervision and appropriate management. So we have 4 pieces of the puzzle where we need to make sure that we have those disease factors that meet the criteria for achieving good response and to this therapy. Patient factors, so can the patient tolerate the CAR T? Do they have good ECOG performance status, good organ function, as well as toxicity risk? Would they be able to handle CRS and ICANS? Do they have infections where basically providing them with CAR T would make things a little bit more concerning? Can they tolerate lymphodepleting chemotherapy, whether it's fludarabine or cyclophosphamide? Could those chemotherapeutic agents cause toxicity? And of course, the logistical and access. So if the patient is, as in the example in the chat that came, if they do live a few hours and they cannot financially and logistically make it to the cancer center, then perhaps seeking an alternate option would be the best case scenario for that patient. Now, this will take us to the polling question. So we consider the scenario: a patient with relapse refractory follicular lymphoma who is a CAR T candidate that asks about outpatient care. When selecting a CAR T product, what factors would you prioritize? And this is a select all that apply. So we'll open up the polling. Okay, so it's actually nice to see that many of you who have, had selected some of them in the pre, it looks like we have a higher percentage of attendees that are, listing multiple. So, we agree that efficacy, safety, patient factors, and of course, logistics and feasibility are all important in this case. So now that will take us to the next part. So we continue with the same patients, and now we're preparing them for CAR T cell therapy. How would you explain, from a pharmacist standpoint or a team standpoint, the concept of bridging therapy, apheresis, and as well as the referral to the specialized care to patients, and how can pharmacists engage in the team-based decision-making and lead that CAR T cell delivery product? Amanda, would you like me to go, or you want to go first?
Go ahead.
Okay, so we believe that the pharmacist is really the center of all of these things in terms of the CAR T cell journey, and we'll go over that in a little bit more detail. We're heavily embedded, whether it's prior to going to apheresis or throughout the bridging therapy or the CAR T cell itself, or even post CAR T. Some things that we feel that are super important is whether, deciding when to take the patient, and even the CAR CAR T product selection, the pharmacists are really involved because we know the toxicity profile, we know the patient's comorbidities, we also know the feasibility and the logistical things that come into place with all of these things. And we also want to make sure that we explain to the patient what we are doing and also explain to our team that, for instance, prior to the apheresis, so the holding therapy is what we call it, maybe we want to make sure we don't give the patient bendamustine, for instance, or something that would impact the quality of the cells that we are collecting. And that's something that the pharmacist can be heavily involved and have a huge impact because we know that certain chemotherapeutics and certain agents can actually impact how well you collect those cells and be able to manufacture them. So that's really where we're heavily involved, and we don't drop off the patient's care throughout either before or after the CAR T cell therapy. We're also involved in prophylaxis, in the chemotherapy, dose adjustments, etc.
Yeah, and I think it's just important to always ensure that the patient has an understanding of the full picture of CAR T, which Tiba is about to go through some beautiful details behind that. But since there are so many different components behind CAR T, from manufacturing to the actual cell infusion, it's important that that education is robust, is comprehensive, and if a pharmacist is the one giving the education, that's always great. Or the pharmacists are at least a part of building and creating that education that will go out to the patients.
Exactly, exactly. And at our center, for instance, we educate our nurses, APPs, and physicians as well. So we collaborate on that education. Perfect. And now with the protocol, so assuming that each patient in these scenarios does proceed to CAR T, how would you plan to ensure adequate supportive care or interventions that are in place for CRS and ICANS? So at our center, for instance, and in our practice, what we try to do is we ensure that we have a tocilizumab that's available. It's in stock, even though the REMS has actually been removed from those CAR T products. We still want to make sure that we have adequate therapies. We also tag the patient's profile to ensure that if they do show up at an emergency department, they know that this patient has received CAR T cell therapy and maybe the neurotoxicity they're experiencing is not a stroke, but it is a neurotoxicity from this product, which is a completely different management that would happen. And of course, we're heavily involved in the guideline development and the guidelines writing. So those are things that are easy access for providers as well as the medical team to be able to quickly go in there and look and see, okay, how do we manage those patients with toxicities?
I agree.
And now understanding that CAR T journey, so really big picture view, what we tell our patients is that you're going to come in, you're going to sit in a chair and undergo that leukapheresis process where the blood is taken out and we collect those T cells, send them off to the manufacturer where it takes a few weeks. During that period, we may be able to give the patient bridging therapy until the product is later ready. The patient receives lymphodepleting chemotherapy, and then those expanded CAR T cells are reinfused into the patient, and then we monitor as we go, but as the CARs are killing and attacking those cancer cells. So that's kind of the big picture and the big journey throughout that we see. But again, we want to make sure that the patient has an understanding that yes, it's a one and done, but we need to continue to monitor throughout that process and even after. And then how we are involved as pharmacists is, again, as I mentioned, it really starts before we even do that leukapheresis. So we ensure that we're coordinating with our transplant and cellular therapy coordinators, the physicians, what's the holding therapy, ensuring that we have proper washouts, assisting with that bridging chemotherapy, or radiation, for instance. And we are heavily involved in the lymphodepleting chemotherapy in terms of ensuring the regimen is correct, looking at availability of medications, dose adjustments, etc., and making sure that we have supportive care therapy. So we start all of the prophylactic agents that, again, whether it's PJP or HSV, VZV, etc. That's all being coordinated throughout that period of time that will continue throughout. And then we do the acute as well as the chronic adverse event management. So even beyond those 30 days, we know that some of the toxicities can linger and stay, whether it's the cytopenias, the hypogammaglobulinemia, or even the infections profile that we have to keep an eye on. And with that, I will give it back to Amanda to take us through the next journey.
Thank you, Tifa. So from here, let's further dive into patient eligibility because I know we're getting a lot of great questions in the chat about that. So we're back to our same patient cases that we've been discussing, but we've added some additional layers, some additional comorbidities. So patient one, who is eligible for CAR T in the second line setting, does have a history of hypertension and mild CKD. So does this change our opinion? Is the patient still eligible? And what real world evidence do we have to support it? And then looking at patient case two, let's add on some layers of diabetes and AFib, although the AFib is rate controlled. So I think these are really great real world examples, right? Because we have patients come in every day that don't meet the check boxes that clinical trials had when they were studying the CAR T products. But I think it's important to note that comorbidities or age don't necessarily preclude a patient from CAR T therapy. And while some aspects of these patient cases might give us some hesitation, we do know now with a lot of real world evidence and involving data that we can still safely adjust and treat patients that have suboptimal organ function or comorbidities that might have historically precluded patients. So looking at patient case one, there is some great data out there now showing that it is safe to treat patients even in CKD. We have even treated patients successfully who have been on dialysis, but it just requires some additional planning of dose adjusting the lymphodepletion, working with the inpatient neuro team, dialysis, and a lot of coordination there, but it has been done and can be done. It just comes down to, like we were talking about before, what product are we now going to give? And can this be administered inpatient or outpatient? So I would still say for case one, we could proceed with outpatient therapy if feasible at your institution. And just knowing that we'll have to dose adjust the fludarabine based on their degree of CKD. But we could still proceed. And I would still say, like I said, it would be okay to proceed in an outpatient setting if all the resources are in place at that specific institution. Thoughts on case two, Tiba?
Absolutely. I mean, I agree with all of these things. This does not preclude us taking patients to transplant. So for example, like history of type 2 diabetes or AFib, for example, it would just make us more aware that the patient does have these comorbidities. So perhaps they may not be able to tolerate high doses of corticosteroids. So perhaps choosing a product that has a lower incidence of CRS and ICANS, or maybe because of that AFib, we want to make sure, okay, we don't do the CAR T cell therapy outpatient, and we actually admit the patient to the hospital where we have good support with cardio team, with endocrinology, and also have that ICU team on the backup just in case the patient does decompensate, where we need to have higher acuity levels. So it's nice that those patients can have these therapies. It just, we have to be very aware and be prepared and be proactive on how we go about managing them.
I agree. And making sure our management strategies are in place, right? So one of the things we're also going to talk about in this presentation is more aggressive or early intervention for CRS. Do we treat at grade 1 or do we just continue supportive care? And patient case 2 with the history of AFib, I would argue that earlier treatment of CRS could potentially prevent worse outcomes, just knowing that with CRS, we might see effects on the cardiovascular system, and we don't want to cause any subsequent morbidity for that patient. So that might be someone that I treat earlier for CRS than maybe a healthy young patient, no comorbidities, could handle some grade 1 CRS and keep supportive care strategies there. And we'll talk more about that too. But looking at these cases, these are all the things that go through my mind when I'm planning CAR T.
Yes.
And um, you, we've talked a little bit about how we have some great data now looking at more real world evidence, right? Maybe patients that don't meet that perfect trial criteria. So let's take a look at some of that data. So here we have real world second line CAR T in large B cell lymphoma showing that even though there are a broader patient population selected, we still see durable efficacy and high response rates. So looking at axi-cell, about 50% of patients in this study here that was presented as an abstract at ASH, really fantastic. 50% of those patients would have been ineligible for a trial, but they still showed outcomes consistent with Zuma 7, even when expanding that population. The same was seen with Lysocell as well. We had high response rates and low CRS and ICANS, which is what we talked about earlier with Lysocell. It's consistent with that publishing data. But it's important to note that this stayed consistent even in older transform eligible patients. We also see that this real world evidence supports safe delivery of CAR T. So it's not just efficacious, but it's also shown to be safe. So we see here that we actually had a comparison of axi-cell or lysocell, and the 6 months overall survival rate was about 89%. Patients who were receiving lysocell were also less likely to experience all grade and grade 3 immune-related adverse events. So essentially, what all this data is showing us is that we have durable responses, good overall survival, and this specific abstract also tells us that lysocell was associated with fewer hospitalizations and shorter inpatient stays when you compare to axi-cell, which again makes sense in the context of what we've been discussing with lysocell having lower CRS rates, lower ICANS rates. So I'm not surprised by this data that was recently came out from Tandem. And more real evidence, more real world findings also support T-cell in aggressive B-cell lymphoma settings. So we see that T-cell delivers comparable efficacy with the clinical trials with low CRS and ICANS. So we really can use T-cell as well in less ideal or selected patient populations when we have appropriate toxicity management. So you'll see overall response rates of about 60%, about 45% of patients included here had a complete response. 24-month progression-free survival was about 34%, and a 24-month overall survival about 44%. We saw that only 6% of patients had grade 3 or greater CRS events, and about 7% grade 3 or higher ICANS. Infections was about 18%, but overall, this safety data was favorable and comparable to what was reported in Juliet. So we see that in this study, even patients with a ECOG of 2 or higher and higher LDH, they do warrant closer monitoring, but we can still proceed with CAR T options in this patient population. So now taking a look at those patient cases again, what are the implications when we, let's say, decide we are able to move forward with our CAR T products, but what happens when there's reduced logistical barriers? How does that impact pharmacy practice? A lot of changes have recently been made in the CAR T world. Like Tiba mentioned, CAR T no longer requires RIM. So, Tiba, how do you see that impacting pharmacy practice as a whole?
So, I mean, I think it's great that the REMS was removed, but that does not necessarily mean that we should not, for instance, stock tocilizumab, or these drugs are all of a sudden not, not associated with high toxicities. What I really think it does is that it opens up the window and the opportunity for expanded access to the centers that formerly did not have these CAR T cell therapy products due to those limitations and the barriers. So perhaps more patients would be able to indeed be able to receive CAR T cell therapy because it maybe a center closer to their home is now has it open and available. So I think that's really the biggest thing that we've noticed with the REMS. It just makes it easier from a paperwork and a legal and a logistical aspect for the centers to maintain it or even agree to bring on a product. Um, but we haven't at our center seen a whole lot of different change just because we've had these products, we've onboarded them, but perhaps centers that have not onboarded might find it helpful, which would be nice for easy access for patients that don't live close to a big cancer center.
I agree. I think that that's truly the greatest impact is uh, maybe making our team more widely available where previously was not. So I'm looking forward to see how it changes more globally, like you mentioned. So we're getting a lot of great questions as well about management of toxicity. So let's transition into how we approach toxicity management. When we look at patients with DLBCL, and we look at the incidence of grade of CRS and ICANS, there are different treatment approaches. So, like we were discussing previously, do you always intervene for grade one, or do you wait till grade two? And then how does grade three change? I know that this practice has evolved significantly over the years, especially the introduction of multiple myeloma products that whose package inserts actually call for treatment in grade one CRS. And I think some of that has seeped its way into the non-Hodgkin's lymphoma world. So the biggest decision point that I think about when I'm deciding, do I treat a grade one, is goes back to those patient factors. What is their disease burden? Do they have high tumor burden? What are their comorbidities? Do they have any cardiac history? Are they more elderly? Do they have a poor performance status? If any of those are yes, then I'm more inclined to treat grade one. If those answers are no, thinking back to a young, healthy, medically fit patient, then we can reserve some of those treatments for grade two and provide supportive care for grade one. But the evidence is evolving when it comes to this. So a lot of it comes down to really risk versus benefit and all of those factors. What do you think, Tiba?
Absolutely, I agree. So I remember as a baby pharmacist, we couldn't give corticosteroids. It was forbidden, right? we
Hmm.
you wanted to wait, and now we know that okay, this early treatment and early intervention does not necessarily impact our efficacy. So we saw that in like the Zuma 1 cohort 6, for instance, with prophylactic dex as well as early TOCI administration. So I agree. At our center, we really try to or do early intervention because we want the patients, if for example they're in the hospital, we want them to be out of the hospital sooner. We don't want the patients to decompensate, and especially for those elderly patients. And we don't really go a lot into detail about prophylaxis, but we also take those comorbidities into consideration when we do prophylactic dexamethasone, for instance, and or other prophylactic agents to ensure that patients don't have higher grade toxicities. So definitely things have changed over the last 10
Hmm.
years of how we go about it.
Yeah, I remember it used to be that the patient needed to be on their way to the ICU before, we were throwing on some more aggressive strategies. But now we have the data saying that there is not an impact on the efficacy or the response rates.
Mhm.
So we can prevent grade two or grade three CRS, not wait for it.
Mhm.
And then when we look at the second patient case with follicular lymphoma, if they were to develop, let's say, grade 2 ICANS, one of the things that I would think about, just thinking back to how we discussed their comorbidities of diabetes and AFib, with ICANS, the staple management strategy is dexamethasone. So in a diabetic patient, you're going to have to consider getting maybe endo involved or maybe an earlier de-escalation of steroids. You can't avoid them, but the as steroid sparing as you can be is generally the approach I take with these patients.
Absolutely.
So, talking about CRS and ICANS, we have a slide here that really compares and contrasts what the hallmark features are. And really, what you see with CRS is fever, hypotension, hypoxia, but it can affect any organ system. Whereas ICANS, what we're really looking for is that altered mental status, speech impairment, and in severe cases, seizures. So CRS really occurs with for most products within the first few days after infusion, while our ICANS is generally later or right, either overlapping with the end of CRS or maybe a little bit of time afterwards is generally when you see ICANS as a generalization across these products. So looking at the product specifics, when we look at Axicell and Zuma 1, Tisacell and Juliet, and Lysocell would Transcend, you see that the the median time to onset is soonest in our Axicell compared to Juliet and Lysocell, or compared to Tisacell and Lysocell, respectively. But our grade 3 CRS incidences are higher in our Axicell and Tisacell products. When it comes to our neuro events, the time to onset is generally 5 days for Axicell, 6 days for Tisacell, and 9 days for Lysocell, with grade 3 events occurring most commonly in Axicell. So again, going back to the questions of how do we choose products, um, we know that there are good response rates across both, but the toxicity profiles, as you can see here, do vary dramatically. So that goes into our product selection, looking at different patient characteristics. So when it comes to the management of CRS and ICANS, we have a great overview of CRS versus ICANS. Really, in CRS, um, you're going to consider tocilizumab or dexamethasone in grade 1, but once you have grade 2, you are treating with toci being your gold standard treatment. There are other treatments available, but we want that blockade. And dexamethasone, of course, and additional steroids get added on as the grade escalates. There are new evolving therapies for treating CRS with good data out there now, such as anakinra. And then ICANS, like I mentioned, really your staple is dexamethasone. And you want to make sure you're preserving airways, you're escalating therapies if the ICANS progresses to grade 3 or grade 4. We got asked a great question about how we manage cytopenias as well. Infection management is definitely evolving within the CAR T space, especially in our lymphoma patients. We see prolonged cytopenias. So, really, what it comes down to is getting a good baseline, ensuring your appropriate prophylaxis are on board, especially in times of neutropenia, and then continuing to monitor throughout the CAR T period. So not just the first 30 days, but routinely, because you can often see those cytopenias happen beyond the first 14 or 30 days. You want to make sure you're checking IgG levels and have your close follow-up because, they are CAR T patients essentially for life, right? So we want to keep a close eye on them, even after the acute period is over. You can treat with IVIG if needed. And then if there is ever an infection event, you want to make sure, especially if you're within the CRS window, that you're ruling out infection versus CRS and managing appropriately. So let's pause here, and we want to know, how do you typically treat grade 1 CRS? So let's say that relapse refractory DLBCL patient is coming into your center with a grade 1 CRS event shortly after their infusion. What is your go-to management strategy? Are you unsure? Do you typically utilize TOCI, steroids first, or observation followed by either TOCI or steroids? CRS is definitely challenging. I think when you go through a lot of ASTC's consensus guidelines, the Lee criteria, it can help form really great SOPs. We are a SOP center. We have an SOP for everything within the CAR T world that I think helps piecewise approaching some of these toxicities. I would say that I would either be a early TOCI or observation followed by TOCI, depending on the patient's tumor burden and comorbidity status. So here we want to discuss the logistics of outpatient CAR T. So I'm going to jump right into what that can look like. CAR T is evolving, and one of the great spaces that it's evolving into is the outpatient space. So I know actually at my institution, we've fully implemented outpatient CAR for all products, unless the patient doesn't meet criteria, right? So all the things that we talked about, they have to have good organ function, a caregiver in place. All of those things need to be there. And the pharmacist really helps that planning. And they work alongside the outpatient team to review medications, make sure the right supportive care is in place, educate their patients, and make sure that there's coordination among all things that are needed to treat the toxicities. There's a lot of great evidence out there that you can safely and effectively deliver these CAR T products through the outpatient setting. I'm not going to go into all the details, they're here for your reference, but we can do this. We can give CAR T outpatient. So, when we're piecing all of this together so far, the key takeaways that I really have for you all is that the earlier line use of CAR T in non-Hodgkin's lymphoma and DLBCL is now approved. So let's start these discussions early. Let's make sure our pharmacists are involved in all aspects of that CAR T care. And when able to, there is the ability to transition to an outpatient delivery of CAR T, again, having those pharmacists at the forefront. So with that, I'm going to turn it back over to Tiba, who's going to talk about now what's next for CAR.
Yes, so that's all exciting. So what's next for CAR? Well, we have next generation cars. So those are like your cool car, Tesla, whatever you want to call them, cyber things. Now, you have a patient who has aggressive lymphoma that you have concerns about bridging therapy. So you basically don't want to wait those, 21 days or however many days after the pheresis to be able to give them the car. What's out there for us? What can we do to basically have the patients achieve and receive those faster cars that take only a couple of days? So what we have here is something called a T-Charge platform, which is something that's still in studies, where you can basically manufacture a car in 48 hours compared to those, 3 to 4 week time point with the traditional CAR T products. And we have some preliminary data that basically shows that we actually have good, encouraging efficacy and safety profiles. For example, the Rapticel product in this scenario shows that was studied in the relapse refractory setting, as well as the first line diffuse large B cell. using that T-charge technology, which is a proprietary method of basically manufacturing that was developed by Novartis, where we look at take the patient's cells, send them for manufacturing. In a couple of days, you already have that product. So you really don't need to do that bridging therapy that at times can be cumbersome or can be of concern, which we saw a question in the chat that was asking about what do we do about the bridging therapy and what agents we would typically select. So here we have efficacy with CRs of greater than 60%, and there's no grade 3 or higher CRS that was seen. And then with ICANS, it's mostly low grade. So could this be the next new thing that we can do for our patients? And how does that impact us from a pharmacy standpoint? So if we are referring those patients earlier, they're not as heavily pretreated, and we're not relying as much on bridging therapy, then this would be a great opportunity and a great thing for patients. With that being said, you also have to time the chemotherapy administration with lymphodepletion, as well as where will the patient be located to achieve and receive that therapy. So with those dual CAR T or next generation CARs, there are actually two different constructs that are pretty interesting. So we have the bicistronic or bicistronic CARs that encode two different CARs on the same cell. So you have two different co-stimulatory domains over here, as opposed to the bispecific or the tandem CAR, which are basically two CARs on the same chimeric protein using that same vector. And we don't have head-to-head data necessarily that's robust and out there, but we know that, for instance, the bicistronic CARs, you could actually use two different co-stimulatory domains. That one could be a 4-1BB and the other one could be a CD28. And this, in theory, could perhaps reduce that antigen escape or could reduce that T cell exhaustion that we are encountering with the current CARs that we're seeing. So could this be a promise as well as the bispecific or the tandem constructs that are there? So we have a trial at our center, and many centers that do CAR T do have some trials that are open. And it's quite interesting to see that not only are we getting those cells manufactured quicker, but we're also now having some dual targeting CARs that are maybe going after CD19 and CD20 or other molecules. So some of the dual CAR strategies that we see and how that really impacts us as pharmacists in the future is that, for instance, Cell, which is a CD19, CD20, this is a tandem CAR or I guess, yeah, a tandem CAR in that scenario. So the way that this has shown good event-free survival compared to chemotherapy. So we're seeing upwards of, high responses with reduction in progression, as well as very low grades of CRS at 5%, and we're rarely seeing any ICANS. So that's really exciting and promising. And then same thing with those Kite products with the CD19, CD20 bicistronics. So we're seeing very good overall response rates and CRs, manageable toxicities, and then we're also preventing that antigen escape that I mentioned. So pretty important, but also valid for pharmacists because now we're addressing that CD19 antigen escape, improving that durability, and we're also now going to be encountering perhaps new toxicity profiles and new onsets of action. So Amanda shared earlier that maybe we're seeing CRS and ICANS at this time period, and it fluctuates between the products, and that can actually drive the decision whether we're doing therapy inpatient or outpatient and how often we're intensifying the monitoring for the patient. With those bicistronic and the dual CARs, this could change where you could have two separate peaks, or you could have a delayed CRS or ICANS, or it could be early on and the patient is done. So a lot to come and more to come from a pharmacist standpoint, because now we also need to make sure that we're ensuring that we're sequencing therapies. The way we call it is you don't want to burn your bridge. You don't want to burn your target. So if we're how do we go about anti-CD19 directed therapies? What should the patient be exposed to, and how does that affect the outcomes? And what are we going to leave for salvage therapies as well? Which a question came in the chat about how we go about whether we're doing CAR T versus bispecific in follicular lymphoma. And maybe Amanda, you and I can address that in a little bit more detail as well. Um, so very important. You don't want to burn those targets, and coordinating the supportive care. Are we going to see more toxicities or different toxicities that now we're encountering in the myeloma space that we didn't necessarily see perhaps? So very interesting and exciting for pharmacists to be a pharmacist in this space and know what's coming, but it's also important for us to be up to date and create those guidelines and also monitor the patients. So now this will take us to the next question, which of the following do you think best explains the rationale for faster manufacturing and or dual targeting next generation therapies? This is great. So many of you have, I see that maybe next generation cars may reduce reliance on bridging therapy and help prevent antigen escape. Absolutely. Yeah. Yeah. And I mean, we could perhaps eliminate the need of standard CRS or maybe have different CRS toxicity profiles. So there's quite a bit of unknowns, but we know that at least that antigen escape and the reliance on the bridging therapy is something that could perhaps be overcome with this. So really the biggest take home or takeaways from those next generation cars is that with that shorter manufacturing time, we may actually be able to use them first line and we don't have to wait because it's so quick where you could start patients with lymphodepleting chemo and a couple of days later give them the CAR. And we know that the dual CARs do have a different efficacy and a toxicity profile compared to what we currently have. And that really for us pharmacists, it translates to being aware and ensuring that we are prepared to adapt to those new and emerging toxicity profiles, as well as how we would go about managing them. And with that, we have a few minutes that we can actually address the questions that came through the chat. Amanda, do you have a burning question you want to answer first?
Well, I think the question about bite versus CAR, I feel like we could have a whole hour presentation on that. That really is it really is a hot topic.
It is, it is. So what we do at our center is obviously, so that was a follicular lymphoma question. And what we really try to do is put both options, if the patient is, of course, eligible, make them aware, make them know of what the risks and the benefits of both. When you look into the NCCN guidelines, there's really no preference. I'm not aware of any head-to-head data that would go over necessarily saying one is preferred over the other. Most of our patients that are CAR T eligible that do opt for CAR T is kind of what we try to do because we know that, for instance, mosunetuzumab does have efficacy and does work after CAR T. So we try to sometimes reserve the bispecific for later after CAR. But again, we've had patients where they're too afraid or they say, I don't want to be too close to the cancer center, or I want to go and receive my bispecific. At the end of the day, we do a shared decision with the patient where we lay all the options and the patient gets to choose.
Yeah, I agree with that. I think shifting gears a little bit, another great question that we had in the chat was what operational steps has your pharmacy team found most helpful for safely implementing CAR T? I would say at the forefront, if you can, ensure that there's an outpatient CAR T pharmacist. embedded within the team because I think that it's crucial for us to not, if we move everything to the outpatient space, that we don't just see the patient upon toxicity because maybe we can help prevent admissions, maybe um, we can help monitor alongside the medical team. So I think that having a pharmacist embedded within that outpatient team is critical for operationalizing that. And of course, education of the patient and caregivers. I don't know if you have anything else to add, Tiva.
Absolutely, yes. I mean, we have dedicated pharmacists, inpatient and outpatient. We also have a 24-hour all year round on-call program that basically is there for any toxicities. We also have APPs that are that do wellness checks for the outpatient CAR T. So we have standardized times where they call the patient in the afternoon as well as at nighttime. And we're actually moving forward with implementing remote patient monitoring, where the patient would have a device that would monitor all of their vitals while they're at home. And from a pharmacist standpoint, we are involved with basically ensuring the patient has all of their prophylactic agents at home, whether it's antiviral, antibiotics, seizure prophylaxis. And, we've even considered perhaps having patients, carry pocket decks in the scenario that we're basically stealing away from bispecifics that we do for our patients. Because I think this is the new thing that we need to be prepared for and make it logistically easy.
Yeah, and I think our nursing team is also goes hand in hand with all of this too, ensuring that the nurses are reinforcing the education at each visit. So, with our outpatient CAR T process, they'll see an APP every other day. But if everything's stable, they still come in daily. But if everything is stable, they may not see a provider, but they will see a nurse every single day. So I think that these are some of the things that we found to be successful in operationalizing outpatient CAR T. We had a lot of great questions in the chat. Any last burning ones for you, Tiba?
Um, I think there was a question about like the durability of CAR T after the 5 years, maybe. Um, I mean, once patients respond, again, relapses typically happen within the first 12 months after CAR T. So usually, we know that we have long-term data for some of the products where we have good CRs, and basically we tell patients after 5 years you're cured, essentially. Uh, so that they are durable with what we see and with the published data. How have you gone about that?
Yes, I agree.
Yeah.
Well, with that, we just wanted to say thank you to everyone for joining us today. Please make sure you visit the link on the screen to claim credit and access the activity materials, and stay tuned for even more online activity based on this event.
Thank you all so much.
Thank you.